Good. All right. Hi, everyone. So a requirement of my program is to present our proposal to an external audience. So thank you, everyone, for being that external audience. So I'll present my chapters and some preliminary results from them. But before I begin, I'd just like to disclose that the funding for these projects has been provided by CIHR and the Can Do Owners Group, or COG. So my thesis has two primary objectives. The first one is to evaluate occupational exposure to low-dose ionizing radiation and whether that increases the risk of dementia incidence or mortality among nuclear power plant workers. My second objective is to do a quantitative uncertainty analysis to evaluate if any of the potentially associated biases are large enough to account for this exposure-response relationship, if we see one or not. Now, this is more of a sensitivity goal rather than a goal to try to correct these biases. This is a very brief overview of the first of the three studies in my thesis. So the first one is looking at the risk of dementia mortality, and this is using phytostats across all of Canada in nuclear power plant workers. And then the second one is looking at dementia incidence in only Ontario nuclear power plant workers. And then that third one is that bias analyses, but I am going to briefly touch on that one because it's still very up in the air. Dementia refers to a set of signs and symptoms associated with the progressive deterioration of cognitive functions. And this is severe to the point where it affects your daily activity and your ability to live independently. Alzheimer's disease is the most common type of dementia, and it accounts for about 60% of all cases. Some other common types include vascular dementia, frontotemporal dementia, and Lewy body dementia. So here's our first poll question. What is the greatest known risk factor for dementia? Good. All right. Yes, the answer is aging. So, get control again. There we go. Most of you were correct. Aging is the greatest known risk factor. And in fact, after the age of 65, the risk of Alzheimer's disease doubles every 5 years in Canada, with about 25% of Canadians over the age of 85 having Alzheimer's disease. There are several modifiable risk factors as well, and the potential for prevention is quite high. According to the Lancet Commission in 2024, nearly half of dementias worldwide could theoretically be prevented by eliminating 14 risk factors that they've identified. I haven't listed them all here on the screen, but some of them include health conditions such as hypertension or high blood pressure, or things like diabetes or hearing loss. But other ones include more behavioral characteristics, like alcohol consumption, cigarette smoking, things like. In 2020, there were over 55 million people living with dementia worldwide, and this number is projected to almost double every 20 years, reaching over 150 million by 2050. There are over 10 million new cases of dementia diagnosed every year worldwide, and this is about one new case every 3 seconds. So for our second poll question, what do you guys think the proportion of Canadians over the age of 65 are with dementia in 2024?
one more.
All right. So almost most of you got it, but it is 8 to 9%. Get control here again. So in 2024 in Canada, about 9% of Canadians over the age of 65 had some form of dementia. Women are disproportionately affected compared to men, and this gap further increases with age. Dementia can also sometimes affect people under the age of 65, and this is known as young onset or early onset dementia. It affects about 3% of Canadians. There are over 75,000 new cases of dementia diagnosed in Canada every year, and this is an incidence rate of about 14 per 1,000 people over the age of 65. Now, we're going to switch gears a little bit and talk about radiation. Radiation plays a crucial role in our daily lives, from medical treatments to energy production, but it definitely can introduce risks if not properly managed. Radiation refers to energy that travels in waves or in particles. And if you think of sunlight, that's a type of radiation. But not all radiations are the same, as you can see in that figure above. Can generally be broken down into two broad categories. You have non-ionizing radiation, which is on that left-hand side, and then ionizing radiation, which is on the right-hand side. Non-ionizing radiation is generally considered to be safe, and it includes things like radio frequencies, microwaves, and visible light. And if you look at that wave that's spanning this electromagnetic spectrum, you can see that the wavelength, which is the distance between those two peaks, is long for non-ionizing radiation. This longer wavelength corresponds to a lower energy level, and that means that non-ionizing radiation doesn't have enough energy to remove an electron from an atom. However, for ionizing radiation, you can see that those wavelengths are really, really short, and this shorter wavelength corresponds to a higher energy level. So ionizing radiation does have enough energy to remove an electron from an atom or ionize it. Now, this creates charged particles called ions, and this process can damage or alter cells in the body. And this is really the basis for why ionizing radiation is harmful to our health and considered a carcinogen. Ionizing radiation can either be in waves, which is things like gamma rays and X-rays, or in particle form, and that's like alpha, beta, and neutron radiations from radioactive material. We're also exposed in two main exposure pathways, and this could be internal exposure, so like ingesting and inhaling small amounts of radioactive materials, or from external exposure, and this is when the radiation comes from outside the body, like X-rays or touching radiation-contaminated surfaces. And when measuring the amount of radiation that one receives, the absorbed dose is in the unit of the gray. However, the potential harm or damage from that absorbed dose depends on factors like the type of radiation and the different tissue sensitivities in the body. And this measure of potential harm or damage is called the effective dose, and that's in the unit of the sievert. So for our next full question, what is the primary source of ionizing radiation for most people? Alrighty. It is, in fact, natural background radiation. So, alright, just keeps popping up. So, exactly, we are all exposed to ionizing radiation. It's ubiquitous. We're exposed through the air we breathe, the water we drink, and the food we eat. And some of these are natural exposures, like from that poll question, and it's That's things like radon, which is a naturally occurring gas that seeps out of rocks and soil, or cosmic radiation, which comes from outer space. And in fact, about 80% on average of our natural background radiation comes from these naturally occurring terrestrial and cosmic sources. But that could vary substantially depending on geography. For example, the mean annual affected dose of background radiation is about 2.4 millisieverts worldwide. In Canada, it's 1.8 millisieverts, but in some regions of the world, it can reach up to 200 times that annual average. That's all based on differences in geology. Now, there are also different exposure settings other than natural exposures. So this could be for diagnostic purposes, whether that be X-ray scans or CT scans, or it could be for therapeutic reasons, like getting radiation for cancer treatments. And although these are important, we're mostly interested in occupational exposure, and that's when you're exposed in the workplace. So this could also be in different settings, like healthcare setting where radiologists are exposed, or in our case, we're interested in the nuclear setting, and this is where our nuclear power plant workers are exposed. Low dose ionizing radiation is defined as exposures below 100 millisieverts. And this has been studied in numerous populations and in the nuclear industry, but most of these studies have focused on cancer incidence and mortality. Likewise, most of the radiation protection guidelines have been heavily influenced by studies of atomic bomb survivors and workers exposed to very high levels of radiation. But we actually don't know if we can extrapolate those health risks that are based on these really high levels to lower doses, which are much more common in contemporary workplaces. International committees generally support what's called the linear no threshold model, or the LNT model. And this posits that your risk from radiation is directly proportional to your dose, and that your risk is never zero, no matter how small the dose is. So if you look at that figure, that's that straight line that starts from zero and just linearly increases as your cumulative dose increases. There are other models like the threshold model, which is where you have no risk up until a certain exposure level and then it increases, or like the hormetic model, which is a theory that very low doses of radiation are actually beneficial to your health. So you have a decreased risk up until a certain exposure when it then becomes harmful. However, all of these models are based on studies of cancer, and the shape of the exposure response curve below 100 millisieverts is still strongly debated. Ionizing radiation is an established risk factor for premature aging by the production of reactive oxygen species causing oxidative stress. This can have serious consequences in the brain because radiation can alter brain cell and cognitive functions and lead to neurodegeneration. Should be things like mitochondrial dysfunction, inflammation, and DNA damage. Over time, this affects your neurological integrity and your brain's ability to function properly, and that's why it could increase the risk of dementia. So let's get into our first study, which is looking at dementia mortality. There have only been a handful of previous studies that have really characterized the risks of dementia in relation to radiation exposure. And these have varied substantially in terms of their population under investigation, the type of radiation, but the most important limitation of almost all of these studies is that they use broad ICD categories to define their outcomes. So for example, most studies use all mental and behavioral disorders or all diseases of the nervous system. And while dementia is included in that, it only accounts for a couple of those codes within that broad ICD category. Some other studies use the combined category of dementia, Alzheimer's disease, Parkinson's disease, and other motor neuron disorders like ALS. But even this isn't specific enough to really get a risk estimate for dementia and Alzheimer's. There have been a handful of studies that have looked more specifically at dementia and Alzheimer's disease mortality. Most of these have reported decreased risks, but some have reported statistically significant increased risks. However, like I said before, these have varied substantially from their population, whether that be nuclear weapons test participants, atomic bomb survivors, radiologists, and even with the type of radiation exposure, from gamma rays to uranium to plutonium. However, the most important aspect of almost all of these studies is that they only capture the underlying cause of death. So on a death certificate, you have a single underlying cause of death and then up to 20 contributing causes of death. And these studies didn't consider dementia or Alzheimer's listed as a contributing cause on a death certificate. So for our first study, we wanted to examine occupational exposure to low-dose ionizing radiation and the risk of dementia mortality among nuclear power plant workers. We also wanted to examine whether this risk differed based on how dementia was listed on a death certificate, whether that was as the underlying cause or as a contributing cause. Doing this allows us to get a more complete picture of dementia mortality. So for our studies, we're using what's called the Canadian National Dose Registry. And this is a registry that's maintained by Health Canada and collects exposure information for about 1 million workers for various radiation-exposed occupations. There are various job sectors that are included in the NDR, and this is from the medical sector to the mining sector, but we're interested in the nuclear sector. About 15% of Canada's energy comes from nuclear power. We have 5 power plants. 3 of them are located in Ontario, and that's where the majority of our reactors are as well. But we also have one that's in Quebec and another in New Brunswick. So we're only interested in workers who have ever worked as a nuclear power plant worker. And this accounts for about 16% of the entire NDR. If you look at this graph, that's showing the mean annual effective doses across different job sectors. You can see that the nuclear sector has the highest annual doses. However, even these are just above 1 millisievert, which is very low. So we conducted a record linkage done by Statistics Canada in 2023 to link individual level NDR records to Canadian national mortality stats. This was a probabilistic record linkage that used personal identifiers such as surname, date of birth, and social insurance numbers. And after restricting to only nuclear power plant workers, we were left with about 100,000 unique individuals. Radiation is typically measured using personal monitoring devices called dosimeters. And these are little badges or rings that workers wear on their torso or their waist. And in Canada, every NPP worker is required to wear their dosimeter to monitor and ensure that they don't exceed the limits set out by the Canadian Nuclear Safety Commission, or the CNSC. The CNSC sets out exposure limits of 50 millisieverts in a single year, or 100 millisieverts over 5 years. And then these doses are relayed to the NDR by licensed dosimetry service providers. And they relay these in accordance with CNSC regulatory requirements. The NDR collects several types of radiation exposures, and definitely not just what's listed here on the slide, but there are things like gamma, tritium, radon, etc. But nuclear power plant workers are predominantly exposed to external gamma rays and tritium. So our exposure came from external whole body gamma rays expressed as effective doses in millisieverts. And although it is gamma rays, it does include all of their exposures that are from different radiation types. So it does include tritium, it includes neutrons, etc. It's just predominantly from gamma rays. So for each worker, we have their ID, and then an exposure year and a dose corresponding to that exposure year. We then created a cumulative exposure by summing up those annual doses, and we use this in a time-dependent manner, lagged 10 years in our analyses. We also only included individuals who had lifetime cumulative exposures below 100 millisieverts, but their individual person years at risk were included up until they reached 100 millisieverts, and then that's when they were excluded. We identified dementia mortality using ICD-10 codes, whether that was listed as the underlying cause or a contributing cause. Now, Although we had mortality data going back to the 50s, we chose to restrict our outcome from 2000 onwards. And this is because that's when contributing causes became available to us. I can't say the exact amount because of Statistics Canada rules, but we did have very few deaths from dementia as an underlying cause before the year 2000. So doing this time restriction didn't change our risk estimates at all, and it allowed us to directly compare dementia as an underlying cause or a contributing cause. So to show this a bit more graphically, we have NPP workers exposed to ionizing radiation as early as 1945. We then followed them through 2020 to identify if they've died from dementia, whether that was from the underlying cause or a contributing cause. Our statistical analyses consisted of two types of comparisons. First, we conducted an external cohort comparison, which allowed us to create a standardized mortality ratio, or an SMR, and this allowed us to determine whether the mortality rates within our NPP workers differed from what was expected based on the general Canadian population. To calculate our expected rates, we applied sex, age, and calendar year specific mortality rates from national rates to those person years in our study. For our internal cohort comparisons, this is where we're comparing dementia mortality rates within our cohort based on different levels of exposure. And to do this, we calculated categorical relative risks, with the 0 dose category being the reference group. And all of our Poisson models were adjusted for sex, attained age, and calendar period. We also calculated what's called a linear excess relative risk, which is a common measure of risk in radiation epidemiology, and it essentially represents the excess or increase in risk above your baseline risk for every additional unit of exposure. It's calculated by subtracting 1 from the relative risk at any given exposure level. The concept of the excess relative risk is very closely related to the LNT model, or that linear no threshold model, because it assumes a linear relationship between your risk and your dose. However, like I said before, that's heavily debated, and some researchers actually suggest that there may be nonlinear effects at very low doses. So let's look at some results. Shown here are descriptive characteristics for the entire NPP cohort stratified by sex. Males made up approximately 86% of our cohort, and they also had the majority of the radiation exposure, having about 4 times on average compared to females. It's not surprising that males made up such a large majority of our cohort, given it's an occupational cohort, but more importantly, it's in the nuclear sector. However, this did prevent us from conducting any sort of sex stratified analyses. Shown here are the number of dementia deaths by cumulative dose category at the end of follow-up. Overall, the large majority of our cohort had cumulative exposures below 10 millisieverts, and our mean cumulative exposure at the end of follow-up was 6.45 millisieverts. So we're dealing with very small doses. Shown here are the results from our external cohort comparison, and our overall SMR was 0.73, which indicates that our NPP workers had a 27% decreased risk of dementia mortality from an underlying cause, or dementia listed as the underlying cause. When stratifying by decade of death or age group, this didn't change, and all of our SMRs were below 1. And this could represent the healthy worker effect, but we can't say that's fully the case, because when we added in dementia listed as a contributing cause of death, all of our SMRs jumped above 1, and our overall SMR was now 1.3. That indicates that now our NPP workers have a 30% increased risk of dementia. And this definitely surprised us, and we still have a lot of analyses to do with this. And one of these is to change the reference population from all of Canada to only Ontario. Because the majority of our power plants are located in Ontario, and that's where the majority of our reactors are as well, that is where the majority of our cohort comes from. So changing the reference population to a more local reference rate, it may help us disentangle if there are any provincial or regional differences in how dementia is reported on a death certificate. Here are the results from our internal cohort comparison, and this is where we're comparing mortality rates for different exposure levels within our NPPs. Those plotted points are the categorical relative risks, and they're plotted at the mean dose with each dose category. So for example, the dose category 0.01 to 9.99 was, the mean dose was 2.21. So that's where you'll see that plotted point there. Regardless of how dementia was listed on a death certificate, almost all of our categorical relative risks were elevated, but not statistically significant. That horizontal line with the arrow pointing to it is the relative risk calculated from that linear excess relative risk model. And we see that the equation here is just that equation above rearranged where our relative risk is equal to 1 plus our excess relative risk, but we see that minus sign because our excess relative risks were negative. That's also shown by that slight downward slope of that line. The reason that we overlay these categorical relative risk models onto our linear excess relative risk model is to see how well they fit with one another. So if it did fit well, we'd see those plotted points following that line well, but that's not what we see here. And this indicates that there's some form of curvature in the exposure response relationship. And with every study, there are challenges and limitations faced. And for us, there was definitely potential for exposure measurement errors. Although personal monitoring using dosimeters is considered a gold standard in radiation monitoring, sometimes these doses could be inaccurate depending on where a worker wears their badge or if they've ever left their badge in an exposed area without them present. But the more significant issue is some doses are so small that they fall below the minimum reporting threshold set out by the licensed dosimetry service providers. When this happens, that means the dose will be reported as 0. And that means these 0 doses could be true zeros, where there's no radiation exposure, or it could just be that the dose was so small that it falls below that threshold and it's reported as 0. To complicate that even further, this can be influenced by the wearing period. So when a worker receives their badge, they'll have it for a defined period of time. So that could be biweekly, monthly, quarterly, etc. And that means that for a longer wearing period at a defined exposure rate, it could result in a dose that just exceeds the reporting threshold, and then it would be reported as a non-zero dose. But for a shorter wearing period at that same exposure rate, it may not exceed that minimum threshold, and then it would be reported as 0. Another limitation with this is the inability to examine the latency period between the exposure and the disease onset. Because we're using mortality data and individuals can live with dementia for 10, 15, 20 years, we don't have a good grasp on when individuals develop dementia after being exposed. In this case, incidence measures would provide a much more comprehensive measure of disease occurrence, and I'll talk about that in a few minutes. The tip of the iceberg refers to the fact that we may only be capturing the most severe dementia cases, whether that's listed as the underlying cause or a contributing cause. Dementia may be more likely to be listed as a contributing cause because for many older adults at the end of life, they have many chronic conditions, and this makes it difficult to assign any single cause of death. There are also various outcome ascertainment biases when using death registrations, and dementia may be differentially reported based on region, type of hospital, and, sorry, I just saw a message on the screen, type of hospital and different factors that are surrounding an individual's death. Now, there's also severe underreporting of dementia and underdiagnosis. This would not only affect primary care records, but it would also affect mortality records. So let's get into our second study, which is looking at dementia incidence. There's only been one previous study that's characterized the risk of dementia incidence in relation to ionizing radiation exposure. This was done by Yamada et al. In 2009 among Japanese atomic bomb survivors. They found a non-statistically significant decreased risk, but these results and these findings aren't directly comparable to our study because the atomic bomb survivors received a single very large dose of radiation all at once, whereas we're more interested in workers who are chronically exposed to low doses, and these may have different health effects. There are a couple studies among Chernobyl liquidators and cleanup workers, but these are similar to the mortality studies where they used very broad categories to define their outcome of all mental and behavioral disorders. So for the second study, we're interested in occupational exposure to low-dose ionizing radiation and the risk of dementia incidence among Ontario nuclear power plant workers. To do this, we're using data held by ICES, which is an independent nonprofit research institute in Ontario that holds all of the health service records for every individual in Ontario who's eligible for healthcare. These are individually coded and based on things like hospital admissions and discharges, physician visits, prescription drug data, etc. And these health records go back to 1986 and cover almost 21 million people now. So we did a record linkage of the NDR data to ICES data. And first, we identified anybody in the NDR who was employed in a radiation-exposed job in Ontario between 1991 and 2022. After identifying those Ontario workers, we restricted it to anybody who's ever been a nuclear power plant worker. Although it was only from 1991 to 2022, we were able to retrieve all of their past exposures. So if they had any exposures before 1991, we were able to get those and add them into their exposure history. After restricting to only Ontario nuclear power plant workers, we were left with about 61,000 individuals. To identify dementia incidence, we use what's called the Ontario Dementia Database. And this is a validated algorithm that's based on hospitalizations, physician visits, and prescription drug data. This is validated in both older adults and adults aged 45 to 65. And it began in 1991, but includes a 5-year washout period to identify any prevalent cases of dementia. So we were able to identify dementia beginning in 1996 until the earliest of either their date of diagnosis, their death, or emigration from Ontario, or the end of the study period, which was the end of 2022. And our radiation exposure was exactly how I described it in the mortality study. To show this graphically, we have NPP workers in Ontario exposed as early as 1956. We then followed them through 2022 to identify if they were diagnosed with dementia. Our statistical analyses were largely the same, and our internal cohort comparisons were pretty much identical. But I'm showing here the external cohort comparison because they differed slightly from that national study, because we didn't have to rely on expected rates. Instead, we were able to match every NPP worker to a random sample of 5 Ontarians who we matched these by sex, age, and area of residence. We were then able to calculate a relative risk between these two groups that approximated a standardized incidence ratio because of the random sample. Shown here are some descriptive characteristics of the Ontario NPP cohort. With just over 800,000 person years at risk, we had a mean follow-up duration of about 13.5 years. Here are the number of dementia cases by cumulative dose category at the end of follow-up. We had 434 cases included in our analyses, and our mean dose was 7.91 millisieverts. We can see that about 40% of our cases actually fell in that 0 dose category. From our external cohort comparison, we found that our NPP workers had a 23% reduced rate of dementia compared to a random sample of Ontario residents. From our internal cohort comparisons, we actually found that all of our categorical relative risks were elevated, and almost all of them were statistically significant. We also found that our linear excess relative risk was positive and borderline statistically significant. Again, we can see that this categorical model doesn't quite fit this linear excess relative risk model, and this was confirmed in this nonlinear relationship by spline analyses, although I didn't show that here. Now, again, this uncertainty analyses, I'm just going to talk about it very briefly because we really have to let the first two chapters guide where we're going with this. So some of the potential associated biases we want to look at include selection bias within the healthcare system. Although we have universal healthcare, there are still systematic differences in who has access to family doctors and who actually attends the emergency department. We also want to look at the degree of underreporting of dementia diagnoses and on death certificates. For our incidence study, we want to look at the competing risk of mortality, because if individuals who are exposed to higher exposure levels die earlier, then they have less of an opportunity to develop dementia. We also want to look at the healthy worker survivor effect and see how these are affecting our risk estimates from our external cohort comparisons. Uncertainty and dosimetry could be an entire course, but just very briefly, we want to look at inaccurate or missed doses and unmeasured doses, whether a worker received doses outside of their workplace. So they went to the dentist and got x-rays, or the hospital and got CT scans. We also want to really explore this pseudo-zero dose category, but this is going to be very difficult because we don't have any indication of true zero doses versus these pseudo-zero doses. We want to see how the wearing period influences this, and also how changes in monitoring radiation over time influences this. As over time practices have changed, and even the type of dosimeter that is used has changed. But again, this is super preliminary, and we don't exactly know where we're going yet with this study. Here are the authors listed on both of the studies so far. And I want to thank all of you guys for listening, and I'm happy to answer any questions.
Thank you, Brianna. We have some questions posted this evening.